Hello everyone out there. This is Dr. Gary Cockrell with Cutting Edge Foot and Ankle Clinic. Today I wanted to talk about a topic called Hallux Limitus and Hallux Rigidus. It's a foot condition and a deformity that we see quite often in our clinical podiatry practice. It has to do with pathology at the great toe joint. This is a foot skeleton of the right foot. This is called the first metatarsal phalangeal joint, or otherwise known as the great toe joint. So basically you have limitation of motion of the great toe, which we call the hallux, in extension going upward like this. So the joint will start out being slightly restricted in extension, and then over time it will become stiffer and much more restricted in motion and quite painful. You'll have hypertrophic bone or exuberant bone, what we call osteophytes, forming over the joint on the top, on the first metatarsal head right here in the base of the proximal phalanx of the hallux, which will cause an impingement syndrome. And again, over time, it will eventually destroy the joint, and the articular cartilage, which allows the joint to glide upon itself, similar to Teflon on a frying pan, will eventually erode down to subchondral bone, causing painful arthritis and pain during ambulation. The causes of Hallux Limitus and Rigidus are twofold, mainly hereditary genetic predisposition, and the other being post-traumatic from just blunt force trauma or jamming your big toe into a heavy piece of furniture. We grade the Hallux Limitus and Rigidus on stages 1 through 4. So early on, it's more of a Hallux Limitus, where you have function and motion at the joint. Even though it is limited, you can still bend the big toe upward to a certain degree. 1 is the earliest stage, where the symptoms are just intermittent and infrequent, or it might hurt you once every week or a couple of weeks or a couple times a month. You should be aware that this is a progressive deformity and condition, so once it begins over a period of years, it will get worse and worse over time. When it reaches stage 4, you have little or no range of motion. The joint is essentially locked up and stiff and almost self-fused upon itself. Those are the worst cases, obviously. There's 2 types of Hallux Limitus and Rigidus. Again, Hallux Limitus is where you still have some range of motion, where Rigidus is more of the late stage 3 and stage 4, where you have very limited range of motion and the joint is very rigid. There's 2 basic types. You have the structural deformity, where you have either an inherent congenital elongation of the first metatarsal, which is the bone is too long and longer than it should be, which will predispose you to this condition and cause jamming of the joint over time. And also along with that, you'll have, again, exuberant bone and osteophytes building up over the bone. Some people call that bone spurs. That's just a general term. So there's actually an anatomical issue with the joint. The other type would be a functional Hallux Limitus. Those cases, at least early on, tend to be a little less severe. That's more biomechanical induced, where you have some hypermobility, hyperlaxity along the medial column of the foot, particularly at this joint right here. And biomechanical forces will, when you're pronating or rolling your foot in the gait cycle, it'll push this metatarsal bone upwards. And the more it does that, the more jamming you'll have. It'll actually restrict the range of motion at the joint. That is best addressed with a functional orthotic. People get fairly good results with those if you catch it early enough. So early on, we try to manage this condition with conservative non-surgical care. Again, custom molded functional orthotics work quite well for this condition, and that can give you relief for quite a few years, especially if you wear them regularly, and buys you more time and slow down the progression of the deformity. The orthotics will oftentimes help restore a little bit of range of motion. You may get a little 10 to 15 degrees extra motion out of that wearing an orthotic in the joint. And at the same time, the orthotic will reduce the stress and workload on the joint too, which will slow down the progression of the deformity. Other non-surgical options would include anti-inflammatory agents, strapping or taping of the joint, which I can instruct my patients to do on a regular basis. Steroid injections can sometimes help, but they're limited to maybe 4 of those a year as needed for extreme acute pain or inflammation or swelling, limiting your ambulation. Physical therapy can also be helpful, but it's not a long-term solution to the problem. So we usually try to manage this condition non-surgically as long as possible. When it gets to a point where it's disruptive to your activities of daily living and causing constant pain on a regular basis, virtually every day, limiting on what you can and cannot do, then it's time to consider surgical intervention. There's 2 ways to approach this problem surgically. Number 1, which is probably the main treatment for this condition for the vast majority of the surgeons, and that would be arthrodesis or fusion of the joint. So that would involve removing the diseased joint entirely. We cut that out with a bone saw. And then this bone, the proximal phalanx of the hallux, will be fused to the first metatarsal, and fixation will involve either screws crossing the joint, or I prefer a metallic titanium plate with up to 4 or 5 screws to hold the fusion site together. So if the procedure works, you'll get a good result. There will never ever be any more issue with the joint because it's permanently fused. The recovery is lengthier. Typically the patients are going to be non-weight bearing for 8 to 10 weeks on a knee walker or crutches. There is a 10% national failure rate. You need to be aware of that, so it's not 100% guaranteed to work. If it does fail, then you have to go back for a revision surgery, which involves a much lengthier recovery. It will permanently change your gait a little bit because that joint is fused. You're going to have to lift your heel up slightly more prematurely during the gait cycle. Most people adapt to this quite easily. If you're a female, you wouldn't be able to wear high-heeled shoes again. Probably shoe height in the heel would be restricted to maybe 1 to 2 inches at the most. So that's something to consider. Personally, I don't like to do this on a younger female for obvious reasons. So the recovery is definitely lengthier with the fusion, but that's the most common procedure for this by most of us surgeons. The other option would be joint replacement, which I tend to prefer that in people that are younger and more active and want an easier recovery and return to mobility. So again, that would involve resecting the diseased joint in its entirety. But instead of fusing the joint, we have several choices of excellent, proven artificial joint implants that would be inserted in place of the original joint. The one I tend to favor is a silicone celastic polymer that has it's a hinged 1-piece implant and with stems that are inserted into the respective bones on either side of the joint, and this will allow early return to function and mobility for the patient and for this joint. Typically, recovery involves wearing a cast boot, what we call a cam walker boot, for about 5 or 6 weeks, after which time we allow our patients to transfer into a comfortable, good quality tennis or walking shoe. So you do not have to be non-weight bearing with this procedure. Typically, my patients will say the pain is much less during the recovery than the pain that they had before the surgery. And again, you'll be able to maintain a great deal of function and mobility in the joint with a joint implant. It's not going to be like you're 20 years old again, brand spanking new, but it's the next best thing. And again, if you're an active patient that wants to maintain function and mobility and range of motion at this joint, it's a good surgical option for many people. I personally have never had any serious complications with this surgery. You'll find things cited in the literature about failure of the implants and longevity of the implants. Some of that has to do with the skill of the surgeon and not putting the implant in properly. But I've put hundreds of these implants myself over the years, and I've gotten excellent results, and I've only had to go back in one time to replace an implant. It was not due to the failure of the implant. The patient simply got older and they had softer osteoporotic bone. The implant loosened up a little bit, so all we had to do is go in and clean the joint up a little and re-cement the implant back into the bone. This was a metallic titanium implant, two-piece, and that was over 20 years ago, and as far as I know, the patient's still doing quite well with that. So there's two options, the fusion and the implant. Probably me personally, I tend to favor the implant just because of less risk of complications and less pain, easier recovery, and again, you get to maintain function and range of motion of the joint, which most people tend to prefer. So a lot of times when you go to a different clinic, a lot of surgeons are not trained in the implant procedure. In their training and residency, they may be only instructed in the fusion option. So they may only present that one option to you, where what I'm telling you with this mini lecture is you have actually two options. You can either fuse the joint or you can replace the joint with an implant. Now, with that being said, to finish up, when we operate on this early on, which we do have a certain percentage of patients that they might need the surgery early in stage 1 or stage 2, you don't really necessarily need an implant. If the cartilage is pretty viable and pretty healthy, we can often get by with just a simple resection of the bone spurs, which we call a cheilectomy. We go in and just recontour and smooth off the irregular bony surfaces of the phalange and the metatarsal. So for a lot of people, that procedure is all they need, or sometimes if the metatarsal is too long, which I mentioned earlier, if it's for genetic reasons, we can do an osteotomy where we cut a wedge of bone out in the metatarsal to decompress the joint and shorten the metatarsal, which would give you more joint volume here. And that works quite well in restoring range of motion. So a lot of times when I do that procedure, I'll do it in conjunction with a cheilectomy, and that works quite well. A lot of people will get 10 or 20 years out of that or longer. Each case is different. And then a small percentage might need a hemi implant, which is where we only replace half the joint, usually on the base of the phalanx here, with a titanium wafer thin implant, which replaces the diseased cartilage just on that side of the joint. Again, recovery for that procedure and the cheilectomy and the metatarsal osteotomy are quite easy. Again, cast boot for maybe 6 weeks and then back into a walking shoe, and you can be weight bearing immediately. So in summary, this is a highly treatable condition. You don't have to suffer with pain for many, many years. You're best off seeing a specialist like myself, a podiatrist, since we see this routinely in our practice, and you have many options, treatment-wise to address this problem, so you can lead a more active, comfortable life and enhanced lifestyle. And this is not something you have to suffer with your entire life. Thank you for your time, and if you need to visit us, just contact us at Cutting Edge Foot and Ankle Clinic. We have 5 offices in the Middle Tennessee area. Thank you.